How are you?
I'm good. How are you?
I'm very fine. Thank you. Thank you for filling the survey as well. Most endometriosis sufferers are going through the same thing, long, like very long diagnostic times. And it takes most of us 10 to 15 years. And once I got diagnosed, I just really was interested in raising awareness about the disease and really bringing change in whatever little way that I can. And yes, and it's really great to go online, because I believe things are a lot easier. Well, online and the internet and social media has made things a lot easier than it probably used to be when Nancy Peterson started advocating. I don't know, I'm sure you know Nancy Peterson. Yeah. Okay, so that's kind of how it has been for me. I started the journey trying to work on my nutrition, my pelvic health, while waiting to see the doctors, and I'm still in that process, but I've learned so much and I've met lots of amazing people, and I just keep talking about it because I know that the more people hear about it, the more they understand the disease, and the more we know that it's not just a bad period. So that's kind of what I've been working on. I'm also working on a project which has to do with basically figuring out what an integrative solution for endometriosis would look like. And before I can do that, I'm trying to understand the problems of endometriosis sufferers, which a lot of them are putting out there. But another thing that I believe is not being, people probably don't understand, are the challenges that healthcare professionals are experiencing with regards to the disease. The survey is one of the things I'm looking at to understand a bit more, figuring out what we need to do. And then, speaking to you as well, I thought it would be great to actually have you on the show, talk about what you're doing. And I know you're not just working with endometriosis sufferers, but because my audience is mainly endometriosis patients, that's why it seems like it's kind of all about that. But feel free to talk more in the course of the interview. Feel free to talk about any other, if you want to talk about your different kinds of patients or whatever, that's fine as well, because I'm sure that some other people who don't have endometriosis but have pelvic pain and chronic pelvic pain would be interested in hearing what you do and finding out how you can help them as well.
Yeah.
Yeah.
Yeah. No, so I see both men and women, so that's kind of the only big difference.
Okay.
People are like shocked about, because men also experience pelvic pain, but they don't experience endometriosis pelvic
Yeah.
unless they're trans. And I've actually seen that too. So it's not uncommon, especially when I guess you would say she is transitioning, when they all of the hormones. So they
Yeah.
get a lot of pelvic pain from the transition.
Yeah.
But males, like the ones that don't
Actual males. Yeah.
have actual male parts, they don't experience the same type of pelvic pain. Because my endometriosis patients have a special part in my heart because they have a systemic condition. It's not anxiety driven. It's not just pelvic floor dysfunction. It's not necessarily a hip injury or a fall on the tailbone, or spinning or biking, that kind of injuries from that. It's or postpartum. I mean, everyone's important, but endometriosis is a full body systemic condition that affects the entire body. So it's not just pelvic floor dysfunction.
Yeah.
So part of one of the major challenges is diagnosis. But for me, because I understand clinically the symptomology that is not just, I'm a physiatrist by training. I treat muscles, joints, nerves of the pelvis.
Right.
And when a woman comes into me, the first question I ask every single female patient is, so how are you doing? All right, we sit down. So let's start from the beginning. When was your first period? And they're like, wait, I came here for postpartum pregnancy, but I still go through, when was your first period? How was it? Was it painful? because I don't want to have to go like do this whole thing and then go back and say, how was your period? Could this be endometriosis? Endometriosis is it's always on the top of my mind.
That's
So
good.
is it all like, I don't bother like what brought you here for the pain. I always ask it because I don't want to miss endometriosis. So it's the first thing I always ask about periods. And then sometimes they're like, no, I have totally normal periods, they're totally regular. And I still think endometriosis because what if it's silent endo?
Yeah.
And so the big challenge is that not everyone's thinking of it. Is it endo? And it's like proven endo until it's not, you know?
Yeah.
I always think it's endo until it's not. And then I'm like, okay, you don't have endo. Maybe I'll just treat you like pelvic floor dysfunction. But a lot of doctors aren't doing that, right? Because they don't know about endometriosis. So the biggest challenge is getting patients, 4 or 5, and then getting them a diagnosis, because sometimes women don't want to be told they have endometriosis clinically. They want to know they have endometriosis.
That's really interesting because I have never actually thought of that women don't want to be diagnosed. We all know that deep down you don't want to be told that you've got a chronic disease, but the way the community, it's like everyone is like, oh, I just want to know. So now hearing your perspective and knowing that this is exactly what I want to do and what I want to know and what I want to raise awareness about, that actually some sufferers are also trying their hardest not to be diagnosed with endometriosis.
Not common, but there are. Sometimes I'll be treating a woman and she comes in for urinary symptoms, and in the back of my head, oh yeah, I have some painful periods, but my periods aren't bothering me right now. It's really, I'm on the pill, it's not so bad. It's just this urgency or bladder pain. And I'm like, but you're not understanding that it could be related.
Yeah.
Like, I don't want to, I'm not going into my periods. I'm not having surgery. I don't want a diagnosis. I'm on the pill. I'm not coming off of it. I'm totally fine. I have some pain with sex. I have some urinary symptoms. My periods aren't that bad, and they don't want to know. They don't. I mean, and I know it's hard to believe because they're like, why would I go through a surgery? And so a lot of times when, especially like in their 40s or late 40s or early 50s, I see some women like, I am so close to menopause. I'm not doing a diagnosis I don't need the surgery to diagnose endometriosis. A lot of them, they're meeting me in their late 40s. They're like, maybe if I had met you like 20 years ago and had some pain with sex, I would have done something, and I would have gone searching for why I'm having pain with sex, but I thought it was normal for 20 years.
Yeah.
So now they're like, I'm okay with this. And you'd be surprised how many women I see like this. Like, it's not just like 1 or 2.
Wow.
It's in a month, I sometimes see like women who are like maybe like 5 or 6 women a month with like who are late in their life, and now I'm thinking endo. Like, I have lots of women who are like, well, I'm just gonna try Orlista because I'm like 49. I'm 49. I don't want to have surgery now. Or they have some other comorbidities, so the surgery wouldn't be like an easy surgery. Maybe they have high blood pressure, or they have hypertension, like heart issues, or they're like, I have some patients who've had strokes, and they're like, I'm not gonna have a surgery to diagnose why I'm having this bladder pain or this bowel issue, or some of them are like, yeah, I was infertile, I never had children, and they don't
put it together,
and they don't want to.
Wow. So how do you deal with that then? How do you deal with those kinds of patients who
difficult? That's
yeah
really, and it's not it's hard because I get it. It's not easy, like, being told that you could have something that's like systemic and then you have to live with it, and then some of them have children and they're like, wait, so you mean my daughters could have this now? And it's a big thing. It's a big, I've actually I remember there was like one review someone had written about, because I was like, I think you have endo, and the person didn't want to believe it and thought that I was like pushing it on them too much.
Wow.
And so, you have to I have to have a balance. Like I can't force people to find out if they have endo or not. They
Yeah.
really have to want to know what's going on. And it's not common. A lot of people are very appreciative and very validated when I tell them that they could have something called endometriosis. And a lot of them see women in like their 15, 16 or teenage years who are now being diagnosed with endometriosis. Like that's early.
Yeah, that's early.
They've only had their period for like 3 years and they're coming in with their parents and I'm like, I think you could have endometriosis. And they are so validated and they're like empowered and they're learning and they feel they want to advocate and create awareness. And so it's not common, but there are both scenarios.
Sides. Yeah, okay. So for let's talk about those that don't want to be diagnosed and don't want to go through surgery. Are there, because now I believe that you can also find out if you've got endometriosis, especially if it's deep infiltrating, through ultrasound scan or MRI even. So do you
Women don't even want to do that.
They don't even want that, really? Wow.
Because sometimes it's not, I can sometimes get them to the consult, but then when they get to the consult, the surgeon's like, well, you probably have endo because I see some adeno, and they're like, well, I'm not going to remove my uterus. I'm good. And that's it. That's where some of them, I can't even get them to a consult.
Wow. Interesting. So they just want to continue living with the pain, or do you basically try to tell them, okay, these are the things you can do in that case to help, or how do you go forward with that then?
So a lot of the symptoms that they have are either presenting with like bowel, bladder, bloating, pain with sex. So what I do as a physiatrist is I try to help those quality of life symptoms. So treating their pelvic floor, giving them some pain options that are non-opiate, getting them into pelvic physical therapy, either having them talking to them about SIBO, the possibility of having small intestinal bacterial overgrowth and being treated for that. So there are still a few things that we can do just to improve the bowel. And like if they're super constipated, talking about, bowels and talking about magnesium and different supplements they can take to improve it, talking to them about diet. If I'm thinking, a lot of urinary symptoms, there's some medications that we can use for decreasing the inflammation. If we might think, let's try some overactive bladder medications, really depends on like the person and what their main symptom is and what they want to treat. If they have concomitant vulvodynia, so a lot of women do because they've been clenching pelvic floor muscles for 20, 30 years. Their muscles are super tight, pain with sex, talking to them about entrance type pain, or there's there's the ONA, the product that with pain with sex, and talking to them about dilators. Obviously if they haven't had endometriosis excision surgery, it could make things worse. So I don't like to do that, but some women are reaching out to me on social media because they have no access to physicians. So I've done like webinars where I can give them links and say, watch this webinar. It's probably the best thing you can get to having a full consultation.
Right. Okay. So you mentioned that if you've not had excision surgery, some of those things can make it worse.
Well, because if there's tissues and implant, you don't know where it is. And so you don't want to be pressing on any of those tissues. And it's just, assuming you've had an excision, the chances of it not being there is better. So sometimes when women who've already had excision surgeries and they still have entrance type pain, I'll talk to them about dilators to stretch the entrance. Okay. But like wands and stuff, if you put a wand in there and you've never had an excision, you might be pressing on some areas that can actually hurt, and you don't know if it's hurting because it's a muscular issue or if it's endometriosis.
Oh, I see. Okay. So there's a lot of talk and like awareness and knowledge about the integrative approach, because I can see like lots of before the I say before, but like a couple of years ago when I started looking into endometriosis, most of my own doctors, like actual Western doctors, were not talking about food or nutrition or things like that. Like there was no conviction but I sense that there's a bit more, talk about it. So would you say, from your experience, like in the last, I don't know, couple of years, are people now aware that a lot of the pain, even if they've got endometriosis, can be almost solved or reduced by seeing a pelvic therapist, or by basically looking at a holistic way of approach, basically? Do you think there's, progress in that regard?
I think that, someone reached out, commented on my social media about what are you doing for people of color or people who can't afford to get treatment. And it made me think, because I was like, what are we doing? And are there a lot of options for people who can't get excision? Because I'm in New York and I know 5 excision surgeons. And if I had to, I would go to one of them and get an excision. But I'm lucky like that. I have, number one, access, financial means, and the education to know who to go to. And so many of my patients in New York have had 3 ablations and then had an excision. And that's in New York, right? Because we're trusting, we don't know, we're not educated enough on the condition. But so for these women who are not getting surgery, who don't have access, who they're basically, the only thing they have are conservative treatment options like dietary changes, acupuncture, physical therapy, removing a lot of the triggers that aggravate them. And they do. I'm not going to say that, when people come to me, they're usually in a lot of pain. So I can't say that a lot of people are completely fine without surgery, but there are definitely women who have no surgery and have an improvement in pain, whether it's with allopathic medications, whether it's just with dietary changes, but usually it's a lot. Back to what you were asking, are there a lot of doctors now doing that? I want to say yes, but unfortunately not all of the endosurgeons are recommending physical therapy. There are a lot that do, but there are a lot that don't. I think there's a little hesitancy that, after the surgery, getting internal work can aggravate them when they're doing physical therapy. But this is not giving an excuse to them, but there's just not a lot of time as a surgeon to talk about diet and to talk about, activities that and exercises that can aggravate them. Whereas I don't operate, I have a lot of that time.
Yeah.
To do it.
Yeah.
I'm not prescribing hormones. I'm not a GYN. So I have the ability and the time to sit and talk for an hour about what you're eating, what are you doing for exercise, when you're in a flare, when you're out of a flare, how can we modify your activities so that you can do things, or what will make things worse. And I think in the world where doctors had a lot of time, they would do all of that. But thankfully, as a physiatrist, I only went into this field knowing I was never going to operate, knowing I wasn't going to do hormonal treatment. So I mean, with all of my patients, I do this, whether they have endometriosis or not.
Wow. Enlightening you have been. So now I think it's really clear what the challenge is.
I just wanted to say that I think the expectation for a lot of patients to have the same care from their surgeon as from their primary care doctor or rehab doctor is like, it's like expecting, like, it's unreal. It's not, I want to say not unrealistic, but sometimes it's a little bit hard, because to expect like your surgeon to spend the amount of time on diet, then they're just going to refer you to a nutritionist. It's just not realistic. Everybody has a specialty for a reason.
Very true.
If you can't find what you want from that surgeon, well, that surgeon only kind of went into it to spend a lot of time cutting and doing surgery.
Yeah.
Not talking about muscles and joints and bones and things like that, and
Yeah.
you wouldn't want your teeth extracted by your, chiropractor,
Yeah, I see what you mean.
but
Yeah. Yes, because actually many of us say, "Oh, I had excision surgery or whatever kind of surgery. I woke up the next morning, or when I came out of surgery, I didn't even see the doctor, or he saw me when I was still coming out of it, said a few things I don't even remember, and now I'm just waiting for my consultation, which is like 2 weeks or 2 months in the future." And we're all like, "Oh, it's not fair. This is frustrating. They don't care." But actually, listening to what you're saying, it's almost impossible, which is why for me, the integrative approach is very, very important, because what you just said it perfectly. You are not going to do what the surgeon is doing, and the surgeon is unable to talk about nutrition. He doesn't even like have the time. He comes in for his surgery, he does what he has to do, and he's on to the next.
right. And I'm not saying that it's, I think every surgeon should visit the patient post-operatively, should be seeing them. And usually here I don't know, I know in the UK it's a little bit harder, but here if you go to someone, usually get a follow-up visit within a week. I'm not, and then sometimes at 5 weeks or 6 weeks. But I see patients like 6 weeks post, like usually if one of my patients has endo surgery, I say come back at 5 to 6 weeks and then we'll talk and we'll see where we're at, and I'll manage their post-op care. So
Right.
I'm managing what medications are going to go back on, what creams I can give them for any pain, what
Mm.
suppositories I can give them for pain, what oral medications I can give them for the nerve inflammation, when they are going to start their physical therapy again. I'm giving them the prescription for that. It's a little bit different in the U.S. because a surgeon's not going to write out a prescription for physical therapy.
Mm.
Usually it's not going to happen. I mean, in some states, patients can go on their own directly to the physical therapist themselves. In some states, after a month, sometimes they need a note, like a prescription from a doctor. So it's not that I'm saying it's fair. I definitely don't, but it's just a little like that when that patient is not with you in the morning when you wake up, he's usually with another patient, like on to
Mm.
the next patient. You know what I'm saying?
I know, I understand. Yeah. So I guess maybe more communication or understanding by the patients about how it all works, or, just, I think patients look up to doctors a lot. Like they're the person of authority and they know it all, even if no one does. But so I think they just usually feel a bit let down, like by everything. But hearing this makes it clearer, and I believe
And I
that.
think the doctors capped their
Mm-hmm.
patient population, and they capped it, and they said, okay, I'm only going to take 10 new patients for the month. I'm not going to take 30. Less patients would get treated, but maybe they would get more time with those patients.
Yeah, so
And
it's kind
patients,
of a trade-off.
it's a catch 22 because then
Yeah,
you won't be able to get into the doctor because he'll say, well, I won't have proper time for you.
yeah,
And that's why so many excision specialists and pelvic doctors go out of network. Where if you were in an academic center in the US, you have to see 30-40 patients a day, and that's just like not enough time. I would be able to be like, so when was your first period? 13? Was it hurt? Okay, you have endometriosis.
yeah,
That's just not going to happen.
yeah, so true. Okay, so do you think technology can make a difference? What are your thoughts on how it can possibly?
Technology is going to. I mean, look at us. We're sitting here in the UK and we're here talking about endometriosis.
Yep.
Technology is the only way we're going to make it better. I think social media has done a huge impact on the diagnosis time. I mean, I like the other day, someone reached out and said my daughter has endometriosis, and I don't want to put her on the pill. And I was like, listen, I can't talk to you on social media, but I can call you and we can talk on the phone for a few minutes.
Mm.
And I barely even let her speak. I just started telling her, I was like, listen, if it was my daughter and she was having pain and she was like missing school for 3 or 4 days a week, I would start with something. I don't want her to have surgery right away. She's just,
Mm.
16, 17 years old. I would put her on birth control. I would see if any of them help. But I would be aware of endometriosis and make sure that if it's time to have surgery and she is progressively getting worse and not improving by any of these birth controls, endometriosis excision, I would be researching the heck out of endometriosis excision surgeons. I would be looking, and I told her these medications that put your daughter into menopause is very different than just birth control, because a lot of people don't understand the difference. They know that Orlissa and Lupron are different than, you know, just
control.
Like low estrogen or a Mirena, or they don't know that. And being aware of your contraception, your birth control hormonal options is really important. And also just like taking away all those taboos that there's something wrong with putting a 17-year-old on birth control. They're not going to go out there and start having sex. Most of the women with endo who are in their teens are terrified of sex.
Yeah.
They're terrified. They can't get a tampon and they don't want to have sex. And so a lot of like the whole like, oh, if I put her on birth control, will she start having sex? That like that taboo like drives me insane. And so I think just these conversations have to be had and people need to hear it. Like, I think even just us talking about this, one mother is going to hear this and be like, oh, maybe I should put my daughter on. Like, allow it.
Yeah.
So many people who, like, literally were not allowed to be, patients were not allowed to be put on birth control in their whole 20s.
Mm-hmm.
And we're told, I think your daughter has endometriosis when she was in their 20s. Maybe you should put her on birth control. And then when they get to their 30s, doctors are like, well, I think she has endo. And the mothers are like, yeah, I know. I just didn't allow birth control.
Wow. I guess it's tough because I think the issue of birth control, I don't even know how I feel as well, but not because of the taboos, not that, but just because that's the thing. There's a lot of information out there, and some of it is like, birth control changes, your body, and sometimes you have long-term effects from birth control. I believe that Lupron and Orlissa, they're a whole nother ball game that's completely different, and that terrifies me a lot more. But even with birth control, I didn't I knew the options, and I think I knew that there were different options, but it was just scary because it feels like, lots of people said all sorts of things. You read all sorts of things about, if you go on birth control, when you're now finally ready to have a child, you might not be able to because your body would struggle to come off, your hormones might not come together properly, or, all sorts of things. So I feel like that's one of the reasons why many people are so terrified, and they don't want their kids or themselves as well to go on birth control, I think.
But so a lot of it are myths. Like even something like, oh, I'm not going to be able to get pregnant after. That's a myth. That's not, lots of women get pregnant, and that's, I think, the important thing about having accurate accurate information out there.
Yeah.
And a lot of GYNs are now joining TikTok and educating young girls, because that's where our girls are, on TikTok.
Yeah.
They're all on TikTok, so they have to hear things like, the myths of birth control. I forget what I was going to say, but I was going to say something. But, realistically, we need to know truths. We can't be getting our information from
just random blogs.
No, blogs and Reddit and, different places. We have to be coming from doctors that are reading evidence or reading evidence-based information and sharing evidence-based information, because and because why? And I wrote an article for a Brown Girl magazine, and the article was something like, the quote was like, are brown or South Asian women causing infertility by accident? Because when you don't talk to your kids about endometriosis, and then the endometriosis now affects your egg quality, you're actually doing yourself a disservice by not being on birth control sometimes, because now the endometriosis grows more rampantly, and now it can affect your egg quality more and now cause infertility, and you're thinking you're doing this amazing thing by staying off the birth control. And it really depends on how aggressive endometriosis is.
Yeah.
Because if you're if you're not having infiltrative endometriosis, it's probably fine. And if you have silent endometriosis, it could be okay. But without knowing how aggressive your endo is, you have no idea. And so I do talk about fertility a lot.
Okay.
Another thing I talk about at my initial visit, because I see women in their 30s and 40s who now can't have kids, and I see women who are in their 20s and they're like, why are we talking about babies right now? I don't want a baby.
Yeah.
But I know what it's like when you're in your 40s and you don't have a partner, and now you're rushed into having a hysterectomy because you have adenomyosis.
Yeah. Yeah. So quick one about Orilissa and Lupron. I'd like to know your thoughts on them and how you advise your patients about it.
If they've never had an excision surgery, I don't recommend going on Orilissa or Lupron. I'm not a gynecologist, but I know that there are a lot of side effects that go along with these medications. And I've spoken to some endosurgeons who feel there is a place for them, but
Yeah.
it really depends on the scenario.
Okay.
But if they've never had a proper excision surgery and they can afford one, and they have the means to get access to an excision surgery, that's always number one. And many of my patients are on birth control, but not many of them are on Orilissa or Lupron.
Okay.
Mostly because of the side effects. Some of them have come to me on Orilissa and Lupron. But yeah, if they come on Lupron or Orilissa, obviously there's nothing I can do. I'm meeting them for the first time, and it's one of those things that, but I don't necessarily recommend it, and I do talk to them about the side effects before they go that way. Many patients will tell me, oh, my GYN is saying that they're going to drop me if I don't do these because these are the only options, or I've already had surgery, so this is my last option, so I'm going to do it. I mean, it's a personal decision for some patients, and some patients are on it and they feel like it helps them and their pain is improved. So I can't speak for it for them, but
okay. So let's go back to technology. How do you usually work? Do you do online or virtual, consultations, and are they helpful if you do?
I don't, because of legal. I have to have a medical license in the state that I see the person.
Oh, right.
So I only have a New York and New Jersey medical license, so I can't. Like, we had toyed with the idea of doing international consults because that doesn't play a role here internationally.
Okay.
But I've been asked, like, how long would you need? And I told them I would need a full hour. And I don't know, there's not enough hours in the day to do a full hour consult. If I had, at least a full hour, but also exam wise, I like to be able to get a sense of what the pelvic floor looks like and how, what I'm feeling. Many of my patients, just by pelvic floor exam, you can tell the difference a little bit in pelvic floor tightness, hypertonicity between an endometriosis woman and someone who isn't. Most of my endometriosis patients are much, much tighter than someone who's just got vaginismus or, a hip injury.
Okay.
It's a lot, I don't do speculum exams. I do it with my hand, but they have a history of having pain with speculum exams and pain with tampon insertion. And so I try to, I can kind of gauge that. And so I don't necessarily think it's a bad idea. I think it's a good idea, but, I think a proper, I know a lot of endosurgeons do phone conversations for consults. And I think it's, I can see if they can do it, we could too, because just having the conversation, I think it would benefit people. But I think one day, I think telemedicine is growing in the US a lot, so I can see it happening.
Okay. Do you have any final advice or anything for women going through pain daily and don't know if they have endometriosis, maybe don't want to know, and just
struggling, really? I tell a lot of my patients to read the book Beating Endo. It was written by Dr. Iris Orba and Amy Stein, who are both colleagues in New York. Sometimes if a patient is kind of on the fence of whether they have endo or not, I tell them, read this book. Or I have a couple of copies in the office, and I'll say, take this book, bring it back at your next visit. Yeah. And they're like, oh my God, I was reading this, and this totally sounds, and I try to let, I let them sell themselves on it, because it's hard. I mean, I can't force it down people's throats. Like, I think you have endo. I think you have endo. Like, if they don't want to hear it. So like good books are great resources. Good podcasts are good resources. If if access isn't there, like I said, getting into physical therapy, getting good nutrition consults. Indomethyline is a dietary supplement that reduces the estrogen in the body. Taking out foods like soy, dipping chemical products that convert to estrogens, removing those out of your lifestyle, improving the blood flow in the pelvis, like yoga, restorative yoga, when you're in pain, like getting into child's pose or happy baby, and doing things that improve the endorphins in your body. So if you love running or you love something, doing that will actually make you feel better. And then obviously if there is any depression or anxiety, that can take you into a chronic pain cycle as well. So working on the things that are in the chronic pain cycle, like muscle spasms and improving the circulation in your body, decreasing the central sensitization, which is a phenomenon of chronic pain, by meditating and doing yoga or acupuncture to decrease that sensitization, and kind of reminding your body that there was a time where you weren't in pain, and that way your body can get back to that time.
Thank you so much.